Welcome to 5-Minute Journal Club, TROP2-directed antibody-drug conjugates in the management of patients with non-small cell lung cancer. This is medical oncologist Dr. Neil Love. I met with Dr. Aaron Lisberg from the University of California, Los Angeles to discuss a number of recent publications and presentations on this subject. To begin, we discussed the dataset presented at the 2024 ESMO Asia meeting and then published in the Journal of Thoracic Oncology, focusing on patients with metastatic EGFR mutant non-small cell lung cancer and disease progression on targeted treatment and platinum-based chemotherapy. The TROPION-Lung01 and the TROPION-Lung05 trials evaluated the TROP2 ADC datopotamab deruxtecan, and in the 117 patients in the EGFR mutated pool, an objective response rate of about 43% was reported, and for patients who had prior osimertinib, about 45%. The median progression-free survival was 5.8 months, and overall survival 15.6 months for this EGFR mutated pool. Regarding safety, stomatitis and oral mucositis occurred in 69% of patients, ocular surface events in 32%, and interstitial lung disease in 4% of patients. Side effects leading to discontinuation of Dato-DXd occurred in 5% of patients, and as a result of these data, datopotamab deruxtecan was granted accelerated approval in June 2025 for recurrent EGFR mutated non-small cell lung cancer in patients with prior targeted and platinum-based chemotherapy. I asked Dr. Lisberg for his take on this pooled analysis and how he uses Dato-DXd in EGFR mutated disease.
We have a new approval for a drug in advanced metastatic non-small cell lung cancer, specifically in the EGFR mutant patients, those patients with sensitizing mutations. And that is a drug named Dato-DXd, which is a TROP2 ADC. We also had an approval in breast cancer, which is beyond the scope of the discussion today. But this approval is based on a subset analysis from two different trials, the TROPION-Lung01 study, which I believe we talked about during our last program approximately a year ago or a year and a half ago, and then TROPION-Lung05 study. TROPION-Lung01 study was a randomized trial against docetaxel that enrolled both EGFR and non-EGFR patients, and the TROPION-Lung05 study focused on patients with actionable genomic alterations, the majority of which had actionable EGFR mutations. And so, interestingly, in this pooled analysis, we did see a really robust objective response rate, around 45% in both datasets, specifically in those patients that had prior osimertinib, which is the patient population we would most commonly be seeing in the United States. These are for patients after progression on osimertinib and platinum doublet chemotherapy. We saw median PFS around 6 months and median OS around 15 months. So these are all clinically meaningful and certainly outperform what we would consider to be the standard of care for these patients, which is docetaxel plus or minus ramucirumab. I think as we're talking about these drugs with our patients now, we should be, emphasizing the good efficacy outcomes as well as the safety profile. I think that when you looked at the TROPION-Lung01 study, again, in the overall patient population, safety signals from Dato-DXd do appear to be more tolerable than what we see with docetaxel, but there certainly are some unique toxicities. And I think the most important ones for us to be talking about with our patients are probably stomatitis, as well as alopecia, ILD, and ocular toxicity. So none of these toxicities are prohibitive in terms of administering the drug, but when we looked at the subset analysis in the EGFR patients, we do see stomatitis is occurring in a little over half of patients, and typically low grade, grade 1, sometimes grade 2, and can be more significant. But I think with prophylactic mouthwashes, including steroid mouth rinses, cryotherapy during the time of infusion, which can be very helpful, and then potential dose delays and dose reduction, we can certainly mitigate and minimize these toxicities for our patients. In terms of alopecia, that's usually hair thinning with this, but certainly something that we need to talk about with our patients, because for some patients, that's certainly a significant concern. And then with many of our other ADCs, as well as our immunotherapy drugs that we use in non-small cell lung cancer and beyond, we should be aware of ILD occurring in a very small subset of patients, but something we certainly need to be watching out for. The final unique toxicity I think that is important to be aware of are ocular toxicities. These are not occurring at a significant rate, occurring in this subset of population in about a third of patients, and typically present as increased increased tearing or dry eyes. If the symptoms become significant, I think getting an ophthalmologist involved is important. So in summary, I think, it's really exciting since the last time we talked. We now have Dato-DXd, this TROP2 ADC for our patients with advanced metastatic non-small cell lung cancer who have EGFR mutations after exhaustion of TKI options and platinum doublet chemotherapy. I think the data does support, both from an efficacy and safety perspective, superiority compared to our standard of care docetaxel. And I think very excited to have the opportunity to give this drug to our patients as standard of care.
Can you talk a little bit about how you're thinking through this clinical decision, second-line therapy in the patient with EGFR mutant disease? Because now we have 3 first-line options.
Yeah.
So I'm curious, both from, in terms of regulatory issues, in terms of what they need, but how you think this through based on what they get first line.
Yeah, I think that's a great question, one that we've been talking about for some time now, because I think it does significantly influence the decision-making process. So kind of going through the 3 potential frontline options, we have our standard osimertinib monotherapy, which certainly is still an appropriate treatment approach for some patients that we see in the office. I think that after progression on frontline osimertinib, a platinum doublet chemotherapy regimen, likely with the addition of amivantamab based on data previously presented, is the appropriate second line, and then you would go to Dato-DXd in the third line. I think in patients that receive amivantamab and lazertinib in the front line, again, I think a chemotherapy, platinum doublet, plus or minus amivantamab, these patients would have progressed on amivantamab, so I'm not sure it's appropriate to continue that drug, but certainly platinum doublet chemotherapy followed by Dato-DXd. I think the last group maybe is a little more interesting in terms of how we would approach it and where Dato-DXd may fall. And those are those patients getting the FLAURA2 regimen. We now have confirmed overall survival benefit for that regimen, which I think is important. That's a combination of platinum doublet chemotherapy plus osimertinib. And I think that, again, the indication for Dato-DXd is after progression on a TKI and platinum doublet chemotherapy, which these patients would have received in the frontline setting. I think that potentially Dato-DXd could be the next therapy for these patients. I think it's a very appropriate choice based on, again, both the efficacy and safety. And so I think you ask a very good question. I think that second and third line choices will be tailored based on frontline therapy administered.
Sacituzumab tirumotecan, SAC-TMT, is another TROP2 targeted ADC that shows significant activity in patients with metastatic EGFR mutated non-small cell lung cancer. A presentation at the recent ASCO meeting and a paper focused on results from OptiTROP Lung 03, a trial which randomized patients to receive SAC-TMT or docetaxel in patients previously treated with targeted treatment and platinum-based chemotherapy. SAC-TMT demonstrated an objective response rate of 45% versus 16% for docetaxel, a significant improvement in PFS from 2.8 to 6.9 months with a hazard rate of 0.30, and a significant improvement in overall survival compared to docetaxel with a hazard rate of 0.49. I asked Dr. Lisberg to elaborate on this data set and the interesting correlation between TROP2 expression and response to TROP2 ADCs.
The next drug we're going to be talking about today is another TROP2 ADC. This one is approved actually in China for patients with EGFR mutant disease, but not approved yet in the United States or elsewhere in the world. So the drug here is called SAC-TMT. It's a very similar drug in terms of design in comparison to Dato-DXd, which we just talked about. It's a TROP2 ADC with a topoisomerase 1 payload. Now here we have some emerging data to really support the idea that this drug is also very effective in patients with EGFR mutant advanced metastatic non-small cell lung cancer. And I think the data here, again, really reaffirms the approval of Dato-DXd and also supports the idea that this could be a very active drug for these patients as well. So at ASCO, we saw an early look into the OptiTROP Lung 03 study, which is a randomized trial looking at SAC-TMT versus docetaxel in these patients with EGFR mutant disease. And we can see an objective response rate for SAC-TMT very similar to what we saw in the Dato-DXd group at 45%, and docetaxel 15% objective response rate. So clearly supporting, again, what we talked about with Dato-DXd, that these TROP2 ADCs, namely Dato-DXd and SAC-TMT, appear to be clearly outperforming the standard of care docetaxel for these patients. In terms of median PFS and median OS, again, we're seeing something very similar, but an interesting difference here. We didn't speak too much about the biomarker in the Dato-DXd story, and it's not directly relevant to the EGFR mutant patient population at this time, but in the past, myself and others had shown that there really was no correlation between TROP2 expression on the tumor tumor cell surface and efficacy of Dato-DXd. Interestingly, in this ASCO presentation, we are seeing some divergence of response based on TROP2 expression levels as assessed by IHC. So when we look at the TROP2 high groups, we're seeing an objective response rate of nearly 60% compared to 20% in the docetaxel group. And even in the TROP2 low, we're seeing benefit, but that objective response rate is 36%. So I think that here, the TROP2 biomarker on the tumor cell surface, as assessed by IHC, may have some predictive nature. Now, it's not a specific enrollment criteria for this trial or for this drug, but interesting, and I think it speaks to kind of some of the differences we're seeing between some of these TROP2 ADCs. Another key difference I'd like to highlight is the toxicity profile of this drug. So we talked about with Dato-DXd some of the unique toxicities. One thing I didn't mention during that discussion is bone marrow toxicity, and the reason I didn't mention that is because we do not see bone marrow toxicity with Dato-DXd. However, with sac-TMT, we are seeing some bone marrow toxicity as well as stomatitis. So we're seeing toxicities of both Dato-DXd and another drug we'll be talking about today, sacituzumab govitecan, which has bone marrow toxicity. So again, something to be aware of, but I think that sac-TMT certainly is looking very promising in the EGFR mutant advanced metastatic non-small cell lung cancer patient population. It'll be interesting to see how the data plays out over time.
Just to follow up on this issue about TROP2 expression, Dr. Garasino, I think, presented at the World Lung Meeting the membrane TROP assay that seemed to correlate with efficacy with Dato.
Yeah, so I appreciate you bringing that up, Neil. So that's definitely an important point to be speaking about. So yes, that was the QCS by NMR. It was a plenary session at last year's World Lung in San Diego. And again, relating back to what I spoke to earlier, the fact that earlier data with Dato suggested that there was no correlation between membrane expression and clinical benefit. What Dr. Graziano presented at World Lung last year was that this new AI-enabled biomarker, which essentially looks at a ratio of both membrane expression and cytoplasmic expression of TROP2. And when the cytoplasmic expression of TROP2 increases, this ratio shifts in a way that makes these patients biomarker positive, and that is correlated with response. Now, we don't know exactly the mechanism of action here or why this biomarker is predictive. We certainly need more mechanistic studies to support that. But I think the baseline hypothesis is we know that TROP2 is trafficked both from the tumor membrane to the nucleus and vice versa. Now, these were essentially biopsies that were evaluated prior to trial enrollment for these patients enrolled on the Dato-DXd studies. And what we saw was that in those patients, again, that responded, there was an increased cytoplasmic expression, suggesting that at baseline, there was TROP2 trafficking from the membrane to the nucleus. And then when the introduction of the ADC occurred, theoretically, there was increased ability to co-opt this mechanism, which led to increased internalization of Dato-DXd and efficacy. So that biomarker, which is a more dynamic AI-based biomarker, is being rolled into a number of frontline trials as well as a number of follow-on trials. So it'll be an interesting way for us to be selecting our patients for Dato-DXd specifically, but certainly is in direct contrast to the data we were talking about for sac-TMT, where that was looking specifically at tumor membrane expression as an isolated factor and potential prediction there.
TROP2 ADCs are also being evaluated in the first-line metastatic non-small cell lung cancer setting, and I asked Dr. Lisberg about 5 papers describing trials with Dato-DXd. TROPION-Lung02, which reported tumor responses with Dato-DXd with pembrolizumab, with or without chemotherapy. TROPION-Lung04, which demonstrated anti-tumor activity in both squamous and non-squamous histology when combining Dato-DXd with durvalumab. To TROPION-Lung07, TROPION-Lung08, and the AVANZAR study, evaluating various combinations of Dato-DXd with immunotherapy. I asked Dr. Lisberg for his thoughts on the combination of Dato-DXd with immunotherapy and the design and rationale and available data from these studies.
We've seen a couple of data sets come out over the past year, updated results from TROPION-Lung04, which was evaluating Dato-DXd plus durvalumab plus or minus carboplatin, and TROPION-Lung02, which was evaluating Dato-DXd plus pembrolizumab plus or minus a platinum-based agent. And then we also know there are a number of ongoing frontline trials. So starting with the data that we know about right now, on TROPION-Lung04 and TROPION-Lung02, I think both trials supported the idea that the combinability of Dato-DXd with a anti-PD agent plus or minus chemotherapy exists. Now, I think that this was not a foregone conclusion before we ran these early phase trials. As we've talked about earlier during this program, Dato-DXd certainly has ILD, again, low incidence and a low rate of significant toxicity. But when you combine a drug that has ILD, such as Dato-DXd, with immunotherapy, or anti-PD agents such as durvalumab or pembrolizumab, which we know have ILD, there's increased potential concern. I would argue from a global sense, the data that we saw in TROPION-Lung04 and TROPION-Lung02 doesn't raise significant concern that there's synergistic or additive toxicity that's going to be prohibitive to combining Dato-DXd plus an anti-PD agent. So I think that that's an exciting conclusion that we've seen in these early phase trials and really support some of the frontline approaches. In addition, in terms of the Dato-DXd's unique toxicity profile, the lack of bone marrow toxicity for Dato-DXd, I think, uniquely positions it for combination approaches with chemotherapy. So the combination of Dato-DXd plus an immune checkpoint inhibitor, anti-PD-1, PD-L1, plus or minus chemotherapy, I think is a very reasonable approach for us to be looking at. So when we look at the TROPION-Lung04 study, again, with durvalumab as the anti-PD agent, we can see both in squamous and non-squamous patients, we're seeing an objective response rate of around 50%, or in the chemotherapy arm, we're seeing an even higher objective response rate in the non-squamous patient population, close to 70%. I think what we're seeing here is data that would be at least consistent with what we would expect with the standard of care, and certainly potentially improved. Now, when I call out squamous patients for these frontline cohorts, I think that's very interesting. We didn't talk about it today, but we certainly talked about it during our last program. Dato-DXd appears to be less efficacious in the squamous population in the advanced metastatic setting after progression on prior therapies, but potentially in combination, we are seeing some benefit in the squamous population. So I think it remains an open question with Dato-DXd. In terms of the median PFS and the median OS based on the different combinations, again, seeing some nice data to support the potential combinability in a frontline setting. And I'd also like to call out some data that was presented at ASCO TROPION-Lung02, which relates to the biomarker we talked about earlier, the QCS by NMR TROP2 biomarker. We did see that biomarker also appears to provide some predictive nature in the frontline setting when we're combining Dato-DXd with an immunotherapy approach plus or minus chemotherapy, again, supporting and suggesting that this biomarker approach could be critical to the selection of patients. So that takes us into what I think are three critical randomized trials to evaluate Dato-DXd in the frontline. We have TROPION-Lung07, which is evaluating patients with PD-L1 less than 50%. That trial is randomizing patients to one of three arms. The KEYNOTE-189 regimen, which is platinum chemotherapy plus pembrolizumab, Dato-DXd plus pembrolizumab without any platinum chemotherapy, and Dato-DXd plus pembrolizumab plus carboplatin or cisplatin. And so patients are randomized to one of three arms. We would anticipate we may have data from that trial in the next year or so, and it'll be very interesting to see how that plays out, either affirming or refuting the idea that Dato-DXd in the frontline for these PD-L1 less than 50% patients can be appropriate. Now, in the greater than 50% patients, the TROPION-Lung08 study is critical. That's a two-arm trial that's looking at pembrolizumab monotherapy, which certainly is a standard of care for our patients with advanced metastatic non-small cell lung cancer and PD-L1 greater than 50%, versus pembrolizumab plus Dato-DXd. I will emphasize that both on TROPION-Lung07 and TROPION-Lung08, these trials are restricted to non-squamous non-small cell lung cancer at this point, based on the data that came out of ESMO a couple years ago and what I spoke about earlier, the lack of benefit in the squamous population. The third frontline trial that I think is critical to be talking about is the AVANZAR trial. That's evaluating durvalumab plus Dato-DXd plus a platinum-based agent. Now, the interesting, unique aspect to that trial is now prospectively incorporating the QCS by NMR biomarker that we've talked about so many times during our program today to select patients, and will help us identify if a prospective analysis of patients selection by QCS for the positive biomarker may be predictive. So a lot of data will be forthcoming. There's also the TROPION-Lung10 study that is rolling in the QCS by NMR biomarker. And it'll be interesting to see how Dato-DXd may perform in the frontline setting in a randomized phase 3 fashion.
Antibody-drug conjugates are also being evaluated in clinical trials in the localized disease setting, and the next two papers describe ongoing studies of perioperative treatment. TROPION-Lung12, which is evaluating adjuvant rilvegostomig, a PD-1 TIGIT bispecific antibody, with or without Dato-DXd in patients with stage 1 disease, and the NeoCOAST-2 study evaluating a number of different perioperative regimens, including the combination of durvalumab and Dato-DXd, which reported encouraging response rates. I asked Dr. Lisberg to further elaborate on these novel approaches to the localized disease setting.
The TROPION-Lung12 trial that evaluated Dato-DXd plus rilvegostomig, which is a PD-1 TIGIT bispecific immunotherapy approach in patients with early stage adenocarcinoma, so stage 1, and using something that's very hot in oncology right now, circulating tumor DNA positivity as a potential inclusion criteria or high-risk pathologic features, which we find in NCCN. So looking at that trial as well as the NeoCOAST-2 trial, which was a platform trial looking at perioperative durvalumab plus a number of different agents, including Dato-DXd. So let's look at the TROPION-Lung12 study first. Again, this is a phase 3 study evaluating patients and randomizing them to receive one of 3 arms, standard of care, rilvegostomig, or Dato-DXd plus that agent. Again, these were patients with early stage disease. I think, it remains an outstanding question how to treat these patients with stage 1 adenocarcinoma. Again, surgery typically cures these patients, but unfortunately, we oftentimes do have recurrence. So anything we can do to increase the likelihood of cure is critical. So these patients were selected based on either high-risk pathologic features such as poorly differentiated tumor, pleural invasion, or pre-surgical CT DNA positive results. They, again, had to have appropriate clinical trial markers such as good bone marrow function. And then they were randomized to these 3 arms. This evaluation is ongoing, but it'll be very interesting to see how this plays out. And I do believe there will be some upcoming data to support potential utility of these agents for these early stage patients. Again, with the understanding that these patients oftentimes are cured from surgery, but there is a high rate of recurrence. And if we can do anything in the perioperative setting to improve their outcomes, we certainly should do that. The other trial that really supports the use of Dato-DXd is very thought-provoking in this case is the phase 2 NeoCOAST-2 trial. This is one that has been talked about for a while. This was a basket trial looking at patients who received durvalumab plus or minus a number of different agents, and one of those agents was Dato-DXd. And so this data was looked at, and certainly in the Dato-DXd plus durvalumab arm plus platinum chemotherapy, we did see improved outcomes. So the patients that had a response with Dato-DXd plus durvalumab plus platinum chemotherapy was 63% compared to 35% with platinum chemotherapy alone. And we can also see that the rates by PD-L1 expression really didn't have a huge difference. So again, Dato-DXd certainly can increase the likelihood of an immunologic response to therapy, but as opposed to some of the other agents that were evaluated that are more immunotherapy based, this agent didn't appear to be as closely correlated with the PD-L1 status. So again, suggesting that Dato-DXd could have a real role in the perioperative setting, increasing the likelihood of major path CR at the time of surgery, which again would be anticipated to improve the outcomes in these patients.
So one question about the adjuvant study, that TROPION-Lung12, which is the bispecific there, rilvegostomig, does it have monotherapy activity in metastatic disease?
Yeah, no, that's a great question. I think that it's a critical question to be asking as we're moving these agents forward. So in this setting, I don't think we have any data to specifically support or refute whether the monotherapy activity occurs. And so we will have to see. I think that these patients, certainly in the stage 1 setting, standard of care for these patients, it's hard to know what to do. In many of these patients, we do simply follow observation. And some of these patients, we will give chemotherapy, potentially followed by immunotherapy. And so we'll see how things play out. But I think it'll be interesting to see what the monotherapy activity is in this early stage patient population that have high-risk features or circulating tumor DNA positivity. And, just kind of relating back to what we do, taking ourselves out of the trial. In the stage 1 disease, it's a difficult space. It's hard to know what to do for these patients. Again, most likely, the outcome for these patients is going to be determined by the surgery. But unfortunately, especially in the stage 1B patients, there is a significant rate of recurrence at some time point. And so NCCN currently recommends the consideration of chemotherapy based on high-risk features. As I mentioned earlier, pleural invasion, poorly differentiated tumor, potentially tumor in the airways. But that's based on expert opinion. We don't have really high-level data to conclusively confirm that chemotherapy is appropriate. And this is a very difficult difficult decision to make with our patients. Of course, chemotherapy at this point is generally safe and generally well tolerated, but there can be bad outcomes, and there certainly is significant toxicity to getting chemotherapy. So making a decision with a stage 1 patient whether they should pursue adjuvant chemotherapy or not in these early stage patients is difficult. And so I think that if we have increased, randomized data to really support or refute the idea that adjuvant approaches would be appropriate, I think that'll be very helpful as we make these decisions with our patients going forward.